Okay, I think for the sake of time, we'll get started. And it's, again, it's our pleasure to continue our GIS program. And it's been a great morning with a lot of discussion and a lot of topics with multiple people involved in it. And it's very successful. So it's my pleasure to introduce the live transmission session at the beginning of this afternoon. And it will be from Saud Babtain Cardiac Center. The operator will be Hamid Al-Ghamdi and Dr. Hussein Al-Zahri. And we'll have a pleasure to have a great panelist, Dr. Arif Al-Nuryani, Dr. Ahmed Al-Jindi, and Dr. Khalid Iskander, and Dr. Mohammed Al-Ataybi from left side, and from right side, Dr. Saleh Al-Ghadir, and Dr. Faisal Al-Nasser, and Dr. Rida Al-Ata. And we'll take it as interactive as much as we can. And before we go to our operator, I would like if we can have the slide of the case. Can I control it? Okay, so I'll just go over the case. It's a 73-year-old female. Has a past medical history of hypertension, iron deficiency, anemia, hypothyroidism, osteoarthritis, and limited mobility, present with a shortness of breath with exertion, almost New York Heart Association class 2 to 3, and atypical chest pain, no syncope or congestive heart failure. ECG, normal sinus rhythm, with the sign of LVH, as we see always with severe AS. Echo preserved LV function, peak gradient almost 72 and mean 43. RVSP is 50. Initial blood work, hemoglobin is a borderline, normal creatinine, BNB is a bit elevated, but clinically she's not in pulmonary edema, and normal albumin and normal hemoglobin A1C. This is the coronary angiogram, and hopefully you can see it later on with Dr. Hamid and Dr. Hussein, but my understanding is completely normal coronary angio. There is no significant coronary artery disease. And the CT tablet protocol showing a tricuspid aortic valve, severe aortic calcification with extension into LVOT, calcium score at the aortic root almost 4,369. This is the measurement of the annulus. The perimeter is 79.1, area almost 460. And the mean diameter is 25.2. And this is the LVOT, and you can appreciate here the amount of calcium is extending to the LVOT, and the diameter, perimeter is almost 77. If you compare it to the annulus, just a bit less, and the area is almost 420. Sinus of Valsalva, again, the measurement is in the left is 30, and the right is almost 28.4, and the none is 32, and coronary ostium in the right side is fine, but in the left or left main is 8.3. And you can see the measurement here by CT, the coronary height, the axis on the left side. This is the right femoral artery. You can appreciate that the axis has a lot of calcium, and diameter-wise is okay, but you can appreciate a lot of calcium in the right side, and also there is a lot of calcium in the left side involved in the bifurcation and the descending aorta. STS score is almost 1.68, and Euro score is 2.46%. So I rather stop here, and we'll go back to our panelist. So we have a case that have a severe aortic stenosis, and there is a lot of challenges at the level of the axis, at the level of the aorta. There is a heavily calcified aortic root and extending to the LVOT, and also there is a low left main takeoff. So I think that's add a more complexity to the procedure, and we'll just take almost 5 minutes to go over it. Then we can go live with our colleagues. So we'll start with Dr. Khalid Iskander. Maybe just before we go in details, do you think with the score of ST score and Euro score here, what do you think in this patient? Shall we go surgery versus percutaneous?
very interesting case indeed, and a bit, it might look easier, but it's a bit complex. But if we look at the ACC and the AHA guidelines, certainly both ways will be, can be done, taking into consideration the patient-specific risk factors. However, if we also look at the European Society of Cardiology and our EACTS Surgical Society, an age of 75 range and above, as long as the risk factors, surgical risk factor, is more than 4, then TAVI is going to be more favorable. Now, having said that, the risk factors, as we've seen here for the patient, whether we take the Euroscore or the STS score, is less than, definitely less than 4%. But in fact, if I look at these patients from surgical perspective, the frailty of the patients and the osteoporosis, all the other comorbidities, the immediate surgical risk of this patient is certainly high. Even though the long-term outcome may be better, but the immediate surgical risk is high. And for this situation, I would probably go more with more in favor of TAVI for the patient's benefit rather than the surgical. This patient's sternum with this osteoporosis, it's like a biscuit. The wires will not be holding it very well and will get into a lot of problems. Now, if I look, however, having said that, I favor the TAVI in this case rather than surgical, and I'm a surgeon. But it looks like there are several anatomical challenges in this case. The location of the low coronary artery, the small sinuses, the LVOT calcifications. There is also calcification in the iliacs. So all of these, it will be interesting to see how in the TAVI operator will deal with this in terms of obstruction of the coronary artery, or what kind of valve is going to be placed, how they're going to protect the cerebral from embolization, and all of these factors. At the results, I think the immediate risk is much favorable towards TAVI than surgery.
Thank you very much. That's a great explanation. And I think that, as it's already mentioned, that there's a lot of issues need to be discussed in this case. So we'll just go over one or two prior to go live, then we'll continue as we go. The first one is an axis. The diameter is great, but there is a lot of calcium. So we have a term of facilitated femoral access. As you know, we have a lot of access. We can go femoral, can go subclavian, direct aortic, and other route. So if we go femoral and we think about facilitated femoral access, what's your take, Dr. Saleh?
Yes, so as every TAVI procedure, the pre-procedural planning is the most important. So in this case, we do have a great deal of calcifications and some hypertortuosities. The diameter it is fine above 7. So in case of any difficulties delivering the system, we could exchange the regular wires to the super stiff wires. That would help proceed the system past the descending aorta.
Excellent. Dr. Faisal, what's your experience with the shockwave? And if you have a problem that you cannot push your device?
Yeah, actually, if we have concern about the diameter, and we think that the things will not go smoothly without help. Usually, we are using shockwave, and we used for a few patients, and after that, it was excellent. But sometime without shockwave, in the beginning, maybe with balloon and with the things that, you know, it can passing the things easily. But I have here a concern about iron deficiency anemia, or which is, it looked like that it's not investigated or investigated, but they don't mention it here. Which MCV is 60, and maybe they're supposed to know about that.
Okay, we'll talk to them about it. As you know, we see a lot of angioplasty with the severe aortic stenosis, so usually have a low hemoglobin. Last point before we go live, Dr. Mohammed Al-Ataibi, left main and risk for occlusion, small sinuses, a lot of calcium, low takeoff.
Can I go to the screen?
Sure,
Smart
you can.
screen? I did drawing before the session. So that's the drawing based on the case. So the metrics here and the metrics of the case. So the left main is low-lying, and the right coronary is high enough. The sinus of the left sinus is 30. We don't have the length of the leaflet or the cusp length. And when we implant the valve, we don't know how much the leaflet goes and reach the left main. But the left cusp is heavily calcified. And if you see it from the CT scan showed, there is a lot of calcium at the tip of the leaflet in particular. So my expectation is that if you push this leaflet, the calcium might reach the middle of the left main. So that's a serious entertainment. So calcium and cusp leaflet. I don't think the leaflet will reach to the stage A, so we are not really entertaining leaflet stage A obstruction. It's the leaflet to the coronary, which might obstruct it, and it's the calcium in this case. So the sinus is enough 30, the left sinus, but the height is only 8.3, so this is an independent risk factor. And the calcium is a lot in the left cusp on top of the cusp. So I will certainly protect the left main. But in case if we predilate, I will make use of the balloon interrogation, because it will show you the behavior of the leaflet and how far does it go, and the calcium, will it reach the left main or no. So I will entertain protection, but I might delay it till I do balloon interrogation if I have to do, which I suggest to be done here because of the amount of calcium. So the left main, there is a risk, and two risk is the low-lying and a lot of calcium at the tip of the leaflet. Now, the right coronary, the sinus is big, 31, the height is 12, and it's not calcified as shown in the CT. So the right coronary, I'm not concerned. So that's probably, you have to remember that this is only today. So my concern today is acute coronary obstruction. That's the metrics. Now, next week, there will be a risk of delayed coronary obstruction, and you need, for that reason, probably you need to go lower, intentionally lower, whatever the prosthesis you want, particularly if you put a long frame, you intentionally should go lower to help to reduce the delayed coronary obstruction. For the future, you have to think of TAV and TAV and risk plane. I'm not going to go into that direction.
Your protection will be only wire in the left main, or you want to put a stent there, just stand by, or you want to do something else?
No, I will not only put wire. I will put wire, and I put probably long stent inside.
Okay. I think that's enough for now. We'll go live. Dr. Hamid Al-Ghamdi and Dr. Hussein Al-Zayer. Do you hear us?
Can you go? And to GIS and to esteemed panelists. Let me just quickly, before we get to the case what we did so far, introduce the team. I have with me Dr. Hussein Zayed, assistant, and Dr. Ahmed Al-Qadaimi. We have Dr. Anesthesia. We have done X-ray, and we have Valerie and Fatima, a circulating nurse, and Sukaina, scrub nurse, with us as well. So I heard your nice discussion so far. Let us, guys, can you go to the first slide, go quickly. So what we did so far, let's tell you, because of all the difficulties you mentioned, and I should just mention one thing before we tell you what we did. This lady, although she might appear low risk in terms of Euro score and STC score, she's actually very fragile. She has very high frailty, very minimal mobility, okay? Despite that, she's extremely symptomatic, okay? So as you saw with the anatomy of the valve, the high calcification, low-lying left main, all these things, constitute multiple layers of difficulties. So we opted in this case because of the high possibility of predilation that we do protection, very high calcium score. I think it would be difficult to do it without predilation. As well as Dr. Al-Ataybi elegantly explained, we need to know actually the behavior of the leaflet. And I should probably share with you the length of the leaflet. Length of the leaflet is 12. But that's not the only concern. As Dr. Al-Ataybi mentioned, you have a chunk of calcium on the tip of the leaflet, and that's a concern to us as well. So we opted to do predilation. So we opted bilateral femoral. Because of this lady's long-standing AS and LVH, we expected that if we did predilation of the balloon, hemodynamics might become an issue for us. The initial LVDP was 34. So we opted to upsize to 18, so we don't have to go sheathless. So we put that in the right femoral, okay? There is calcification, and it's not here in femoral, significant calcification in the iliac and at the bifurcation as well. So we put a French on the right side, we put a French on the left side. We use both radial axes. We did using the right of the coronaries. We decided to go up front with the protection, okay? As I said, the possibility is, I wouldn't say high, but it's concerning. So we decided to go up front with the protection. Do they see the?
Yes.
Yes. So that's what we did so far. We crossed, and the mean gradient here is 50. 50 by invasively, it's I think 48, is it?
Yeah.
By echo, so it's concurrent to echo, 50. So we're ready to go ahead and do balloon dilatation. I can probably just leave it to Dr. Hussein to explain to you the size of the balloon that we decided to go with.
Okay, thank you, JIS, for this kind invitation. So basically, in terms of the area and perimeter, we went basically by the minimum diameter of the iris and the ability as well. So in this case, we plan to pre-dilate a 20 millimeter new med balloon and go from there. We're currently to proceed with introducing the open feeder stiff wire followed by pre-dilatation.
So what the size of the pre-dilatation you select?
20.
Yeah, so we selected a 20 millimeter new med balloon based on the measurements of the area and the minimum lumen diameter. So we'll go with the 20 millimeter new med pre-dilatation. Given the calcium score, usually in our protocol, we have a high calcium score of 2,000. We can pre-dilate these cases.
I find a difficulty of hearing you, Dr. Hussein.
Yeah, so usually our protocol is when we have an elevated calcium score.
I
think your device is touching something that's giving you. Hamid, can
okay.
you? Yes.
I'll just pick it up from here. Forward. So the question is pre-dilatation. Pre-dilatation, if we have a heavy calcification, or severe calcification more than, whether you use the American or the European guidelines, this lady is far and beyond severe. It's very significant. So we decided to go ahead and do pre-dilatation. And the decision of the size of the balloon to go with the minimal diameter. I mean, when you look at the CT data, I think you notice that it's elliptical. It's almost 20 by 28. Okay, that's the most consistent measurement of the aneurysm. So we opted to go with the 20 millimeter balloon. I think that would be enough to give us, prepare the area first and give us actually an indication of the interaction of the leaflet with the left main, which is which is one of the main reasons that we do pre-dilatation.
Okay,
In this particular
maybe we
case.
should pause for a second here, and I will just reiterate what's your plan here. So you already put a wire in the coronary, you put a stent, and you plan to do pre-dilatation, and you already have a cerebral protection. Anything, Dr. Arif,
Yes.
different, or you agree with this plan?
I think so far we are all agree upon what was planned. I didn't get it. Is there any cerebral protection device in place? I didn't catch
Yeah,
that.
just show it to them. We'll show it to you, Fawaz. Let's just show it to you back. Okay, just go back
Right,
quickly.
right. So it's there.
Back.
Yeah. So I think that is a very good option, especially with this heavily calcified situation in the valve. We are expecting some debris to be captured in that for sure. Later we may discuss the advantage of this or disadvantage.
Great. Are all people agree with your strategy, Dr. Hamid here, so you can
So
continue?
Fawaz, let me just allow you to tell you, just add one more point. I did not mention it. We decided in this because we're using 18 French sheath. We decided to go with 2 ProGlide. I mean, our practice with the usual 14 sheathless approaches, we go with 14 and one ProGlide. In this particular case, okay, because it's large, we decided to go with the, upfront 2 ProGlide. Back to you. Okay, let's go.
How long is the stent for us?
I have a question here. What's the size of your stent?
22? 5022. No. 18? 5018. We don't have 22. Okay.
Okay. So Dr. Rida Balata, maybe we'll just use some time here. So we already mentioned the pre-dilatation. So we want to understand what do you think about pre-dilatation? It's not usually routine here. So what's the amount of calcium that's pushed you? And do you do it with all cases? Is patient with a specific for this patient, or in general, is anyone should have it? What about tricuspid aortic?
Just go with the feeder, please.
I guess that getting a routine pre-dil is not our routine practice, actually. If we have in the CT, the commissures are not fully fibrosed, and the leaflet calcium scoring, it's not massively incorporated with this type of calcium. But the most important in this patient is the balloon interrogation to see what is the behavior of the leaflets. And usually we have to do it in the projection that we can see the ostium of the leaflets, of the coronaries, sorry, which should be in the LAO projection. It's not in the AB on the cusp overlap. Because I need to see the behavior of this lump of calcium. It is moved toward upward and toward the coronary to do any compromisation of the flow to the coronaries, or we can see this. The other issue, they safely selected a bit undersized balloon, which is to the minimal diameter, which is 20 millimeter, but we have to be very cautious of the type of the balloon and how much the displacement will be by the valve. So the valve, say if we selected a core valve, this area will be 23, and it will be bigger than the side of the balloon. So we have to mimic this difference in 3-dimensional. I have to imagine I use a 20 millimeter balloon, so if my lump of calcium is significantly nearby, I have to remember that the valve will give me more approximation of this leaflet tissue toward the coronaries, because it will be a 23, not 20.
Great. Dr. Ahmed Al-Jindi, LVOT calcification. What do you think about that? Does that increase your risk for rupture, increase the risk of paravalvular leak or PBM?
So I think that the choice of valve here makes sense, in all honesty. A, for the coronary height, I wouldn't want to use a balloon expandable valve. 2, using a self-expanding platform is going to be gentle, especially, is going to be kinder on the annulus on the whole, especially in the presence of severe LVOT calcification. Breda's comment is absolutely pivotal. When it comes to pre-dilatation, you are interrogating the behavior of the leaflets themselves. You don't want to overdo it, otherwise you risk losing the advantage that comes with a self-expanding platform. But you also don't want to undersized the balloon, because in all honesty, I would probably have used a 22 millimeter balloon. Although classically you would go with the minimal diameter, but on this particular occasion, I want to understand how the leaflet would behave, and putting the projection where you actually see the ostium, and this can be something you derive from the CT in advance. So it's going to be interesting seeing how that valve behaves on the whole.
Great. Hamid, back to you. You are preparing to do pre-dilatation, so.
You know, very valid points, actually, very nice feedback. So as I said, the choice of the balloon, we thought that that would be enough actually to spray both leaflets, to give us actually a good idea about the behavior of the leaflet and interaction with left main. So we're going with we just crossed with with 20 by 50 balloon. Can you give us intracranial? And you know, with the projection totally we need to see it in cranial projection. Just give me a second. Test. Just release the nice. Okay, just advance it a little. So we're gonna go ahead and just do the EAD right now. Okay. So go to pacing on 180. 180. Okay. Good. Yalla. Inflate.
Inject, Sydney.
Inject.
Okay, and down. Wait.
Two questions.
Okay.
You need
So,
to do
okay.
protection before balloon? Or
Flora,
can you do the
we
balloon
got the
Yeah,
after
let's just take it out.
You said to the panelist, huh?
Okay.
I will do balloon before protection.
Flora, Hamid, Flora. No. I need to see the sheet, and you need to hold the sheet.
Yeah, go.
I think I.
Can you run the back? Yeah.
Okay, valve.
Okay.
So Dr. Ahmed.
Show us the injection. Okay, back to you, Fawaz. You just look at that. Just show us.
Yeah, we're discussing while you're doing it. It's not a little bit low, but the point had been raised is usually balloon dilatation before you protect left main, then you can put wire after that. And if you do protection prior to balloon, maybe it's the guide should be built up a bit, not to prevent any injury. Is that your point?
You see it, Michael. Yes, I wouldn't put the guide while there is a good risk. The left main here is clear, it's nice, they are doing a good job, but there is a good risk of pushing the guide.
Yeah. Yeah.
Flora.
Just show, you know, leave that one. Okay.
Hamid.
So what size of
Yes.
valve?
Yeah.
So you already balloon now and are ready to put your valve? You didn't tell us about the size of the valve that you select.
So based on the just rest. Based on the derivative of the annulus, which is in the almost mid to high range of 29. So we decided to go with Evolute 29. Now in this case, with heavy calcification, we need a platform that will give us a good reading force. Okay. So that's why we decided to go with the self-expandable valve. So 29.
Hamid,
FX.
can you just ask them to run the balloon dilatation again? Because I think it's important
Guys, can you run it, please?
that you guys in the lab tell us what are you seeing,
Yeah.
how do you reflect on that? Because this was done essentially, besides the calcification, with the intent to interrogate the behavior of the leaflet. So how are you seeing, Hamid?
Absolutely. You know, what I can see probably the slight compromise of the flow actually of the RCA more than, and as well as left main. So, but the question in this situation, is it because of potential obstruction, or is it because of we had basically no blood, you know, when we went up to 180, we had almost no blood pressure, okay? So it could go either or, but I don't see complete obstruction. So I'm confident to a certain degree that actually we're moving in the right direction.
So this balloon is basically undersized. We measured a couple of times, and we decided to go with the minimal lumen diameter and the minimal area, because the second time we measured, the perimeter was actually below 79, but still in the 29 FX range. So that's why we decided to go with the
Okay, Dr. Mohammed Ataybi?
Hamid, do you think you need a longer stent? After the balloon angioplasty, there is entertainment of calcium going into the middle of the left main. Do you think that this length of the stent is enough? Because you choose the longer frame, so you need to bring the stent back out of the frame into the aorta. So you think the length is enough, 18 or?
So basically, if you like me to answer, so
Go ahead.
Based on was
No, we're getting.
only need to go above the STJ. STJ in this patient is not that high, so we only need to go above the STJ. We don't need to go above the frame. So I think an 18 or 22 millimeter in length would be fine. We don't want to touch the LAD. We only need half of the stent in the left frame, and the other half.
Great, that's obvious. I will just take one comment, then we'll go back and see what.
Fawaz, allow me just to add one thing.
Sure,
You know,
sure.
the 29, you have the circ of 13, okay? So circ is not actually our circ. You go to the commissioner height, which is 26, okay? We're aiming at lower, deployment in this case. So I think this length will be enough to get it actually above and safe state, all the way up. The frame. I think all we need to do is above the commissioner, which is 26 minus whatever is going to be below. I think that's it. And we're going to land it in left main.
Great. Are you ready for valve deployment now?
Yes.
Yes.
Okay. So,
Okay.
Dr. Rida, are you happy with the balloon dilatation?
It's a technical comment. When we are going to do this job, the big tail should not be preferentially in the non-coronary cusp or impacted in the right coronary cusp, because the backflow going to the left cusp was very sluggish and very delayed. If he pull up the big tail a little above, you will see the contrast is filling the three cusp at the same time. So usually when we do this one, I prefer to take it at least 2-3 centimeter above. So you will see how much the filling of this cusp. To me, the leaflet is very bulky. The lump of calcium is definitely bigger, far away than this balloon. This nucleus balloon is hardly touching the 20 millimeter by my visual estimate. It is even less than 20. So I have to be much more cautious. One issue here, what is the technique, what we are planning to do for the coronary protection here? Is it a snorkeling or it is a chimney? Snorkeling, you don't have to go that far away. But if chimney, as you mentioned, or they mentioned, to go to the STJ level. The second point, I'm wondering why the stent in the circ is not in the LAD, which is, I prefer to keep it in the left main LAD. It's not left main circ. The proximal segment of the circ is far away, bigger, matched better with the left main, but still this is the LAD, so we'll not have the time. I cannot see properly he is using a guideliner extension or not. If we planned to do the case by this way, by the end of the procedure, if we don't have to put the stent, taking the stent out with a fully expanded frame, it carried the risk of peeling out or slipping away. So it is far away safer to keep a guide extension inside as well. It will be much safer to take it.
Hamid, so we'll stop discussion at this level and we'll go back to you 100% and just do your procedure and watch you.
We do have actually guideliner, and the plan would be to pull the guide, okay, once we attempt and actually just leave the guideliner at the end. Please,
Okay.
ready?
Okay.
Go. Okay, let's just stop here. Okay, just brilliant. Go. A bit more. No, the other side. Good. I think we're good here. Yeah, we're good. Nice. Okay.
We're at 12.
We're 12?
Yeah, we're at 12. So we need to keep it.
Okay. So, Huda, yes. We're just taking our time slowly because we have a lot in the aortic arch. Okay. Good. Okay. Okay, let's just stop here. Okay. Just go to the cusp overlap. Ahmed, just ready? Can you just be ready with the injector? Okay, just leave it here. Okay. Okay, ready for crossing? Test. Give me a test. As I said, we are aiming actually at lower implantation here. Okay. Good. Stop. Test. Test. Good. Okay.
Step on the line, please.
Yeah. Okay.
You want to advance a bit?
Test, please. Yeah. Advance. Advance. Test. Test. Good. Test.
Okay. Do you want me to start here?
Yes.
Okay, looks good.
Small test, please.
Small test.
Good. Yeah. A little lower. Okay. I'll just keep pressure. Good.
You want to start pacing?
So you are doing
Okay.
it in the cusp
Gonna move
overlap, right?
Yes. This is cusp overlap. Okay. Pacer on, please. Test. Test. Yeah. Let go. Go. Pacer on.
Rapid pace,
Pacer
180.
on. Pacer on.
180 maximum output, please.
Go,
Okay,
go.
we have capture.
Test.
Test.
Test, 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 test. Go, go. No. Walk it down, walk it down, walk it down, walk it down, walk it down. Off pacing. Fluoro safe, please.
Okay.
Okay.
Yes, please, you fell.
We don't see the hemodynamic. Can you show the hemodynamic to us? if you can?
Okay. Please, can you pace at, are we losing capture, Hussam?
No, we're good.
We're good?
We are good.
It's back. Okay. Blood pressure is good. Excellent. Okay. So pressure is building up. Okay.
So for the technical guys, can we please put the fluoro on the big screen and the hemodynamics on one of the smaller screens?
Can you come more caudal, please?
Yeah.
More caudal.
More
More.
caudal. More caudal to remove the parallax.
Go.
More caudal, please. More caudal. Okay, we're good.
This is, go.
More.
This is extreme. Go, more, please.
Okay, I think that's good. Okay, let's take a picture here.
Okay, let me just give you. Yalla, ready?
Cine. Inject.
Inject.
Cine.
Go.
Inject. Okay.
Yeah, that's good.
Okay, so we're at 3. And we do have flow in the left main, so we should be fine.
An RCA.
An RCA. Let's go to the LAO, please. Would there go LAO? Yes, please.
Okay. Okay.
Good, that's excellent.
Okay, just move it towards me. Or more. Okay, nice. Ready?
Go ahead, Cine.
Go.
I think we're good.
Okay, so Fawaz, we'll stop here for a minute. What do you think, guys?
So Dr. Mohammed Ataibi, what do you think?
I think it's okay. I can still see the flow in the left main, the right coronary. I'm not sure from here how deep is it, but remember the target is to go deeper, like 5, 6, if there is no block. So do you see any block on the ECG?
No,
We're good.
we're good.
Do you think the depth is
Hassan?
5 to 6?
It's not. I think it's around 3 to 4, Muhammad.
It's okay. If you are happy, you see it better than us, but I think if it's I think this is good, and I like the frame in the middle of the aorta, so there is no a lot of tension on the prosthesis, I will take it. If you are happy about the image you have in the lab, much clearer than I will take this.
Maybe I'll ask all the panelists, do you think that the position is okay or a bit higher than what you should expect? Can we start from Dr. Rida? You are okay with the position or no? Yes or no?
I think it's okay. It's not our target. We opted for a little bit lower, but I think it's okay. It looks fine.
Okay. Dr. Faisal?
I think it's okay, the position is okay.
Dr. Saleh? Okay. Dr. Arif?
I think it's acceptable. We wish to be 1 2 millimeter deeper, but it's okay.
Dr. Ahmed?
I would take it.
Dr. Khalid, okay? Yes. So we have almost 100% panelists think that the position is okay. You already have a flow in the left main.
Unanimous voting? Well, that's good. Okay. So I think we'll take it. Just ready, guys? Let's just go ahead.
Okay,
Pacer on.
Pacer, rapid pace.
Go. Yeah, just go ahead. Go ahead. Pressure. Go. Nice.
Slowly, Hamid, slowly. You don't need to
Go. Yeah.
slowly here.
Yeah.
And
Nice.
there's a bit of tension on the wire.
Down, go down. Go down. Walk it down. Fluoro safe. Stop.
So very steady.
Yeah.
You have both pedals off.
Yes. Yeah, we're good. Okay. Give me.
Hold the sheet.
Enough.
Dr. Rida, do you still leave the stent there or you pull it back? Or?
I have two comments. First, we all the self-expandable valve, we have to ensure that the big tail is in the nadir of the non-coronary cusp. It will be very helpful because of the dynamicity of the right coronary position in variable views. I prefer to make sure that I'm in the non-coronary. The second point, I do not remove the safety staff except when I have the decision I'm going to do a balloon or not. The frame is fully expanded to make sure that I have a good flow. I usually inject from the big tail. Sometimes we have to pull the guide a bit back, little bit as a cusp direct injection to make sure that we see every relation of the ostium of the coronary.
I think I would like to ask about basing. It's most of the patients, they are sick and old, and you should not initiating basing unless it is necessary, especially in the first stage of the deploying.
I think that will accept it, especially nowadays. I think with the self-expandable, you don't need that much basing. And if you want to do it, you do it at a rate that you just decrease the blood pressure, not to have a flat line. So I think all people here waiting for your aortogram, Dr. Hamid.
Yeah. Okay.
Wire, please.
Yeah. Let's just do it.
Do you want to remove the
No. We'll just freeze it. Just give me the wire.
J
Just
wire?
regular wire. The wire, guys.
Please give me the picture.
So just to feedback, we have excellent hemodynamics. We have normal ECG. We don't have any issues so far. Can you just release the wire? Just relax it because it's fixed.
I got it.
Okay, good. Take it. Just take it. Huh? No.
Hamid, while you're waiting for your check injection and for echo, do you mind going to an REO projection? We want to understand whether the frame is fully expanded.
Yeah, just give us 1 second.
Yeah.
Okay, can you just go to cusp overlap, please? Huh?
So that's good. So that probably minimizes the chances of needing post-dil. That's
More
good.
cardio, more cardio.
More powder, go.
More cardio.
Where is it?
Go.
Just take it.
It's well expanded.
Because it's
Yep. Looks quite good.
Yeah.
I mean, this is
We're good. We
yet
can take
one
this.
other added advantage for a good pre-dilatation. You avoid, in this particular scenario, going a post-dilatation with obviously a higher risk of coronary obstruction because the choice of balloon will be bigger by nature.
So we just prepared to take the hemodynamics, then after that we'll do the injection. Then we'll revisit the need for post-dilatation.
Okay, so maybe while you are doing this, we'll ask about the cerebral protection. Dr. Arif, we already mentioned it's nowadays the data is up and down, so what do you think?
We have now the really solid data from the randomized trial that been published in New England Journal of Medicine 2022, showing non-significant actually advantages from the cerebral protection device compared to none. But again, there are a lot of controversies, and we are waiting for the BHF trial coming up next year, probably. That will be really confirming where we are, but not very sure. Still, either you are a believer or non-believer, we are still talking about this, and I'm one of the believers that this is really of adding benefit. Particularly, I mean, it makes sense, logically it makes sense. You see 99% of your filters are filled with debris. We have even the disabling stroke results, though the number of stroke were not significant in the trial, but the disabling stroke were something like 1.3 to 0.5%. So this difference shows that there is some kind of advantages there. Plus, we are moving more and more toward the low-risk cases, and we don't know much about the cognitive long-term impact of this. So that is all kind of things that we are waiting for this really large trial to come up with more insight in this.
Ready for injection?
Guys, can we put the hemodynamics on the big screen, please?
Yeah. Guys, can you show the hemodynamics? So,
Big screen, please.
but 15 mean pressure.
Okay, so your LVEDP at baseline was what, Hamid? Sorry, we missed that.
34. What is
34.
it now? Is it 25? What is it? Yeah.
Looks like
LVEDP.
20 where we are.
Huh? 28. So I think we're it's better. Okay. Let's take injection and see. Just fill it with contrast. Fill it.
Additional to Dr. Arif's point of the cerebral protection device, usually we categorize the patient. The regular risk
Okay,
or a
fluoro on
high-risk
the big
group.
screen now, guys.
Some of the high-risk groups, similar to the valve-in-valve category, and
push it down
patients
for
with
me. Down.
significant calcification of the ascending aorta, we know that the interaction of the delivering the system and with the leaflets, with these degenerated hypothesis leaflets, usually it carries much more risk.
Okay.
So if contrast is not an issue,
I-
do you mind taking an LEO shot as well? Just to understand how the leaflet
LEO.
is behaving with the left corneosteum?
Elio, and a bit of
Look like a great position. The coronary, we can see it both LED and LCX.
Yep.
There is
Yeah,
no much
sure.
paravalvular leak, and LCA is fine.
no.
Less cranial, less cranial.
Test.
We're good.
Good. Just
ahead.
اسحبي يا جهتي. Yeah. Just towards me, please. Good. Ready? Go.
We have to.
It's good.
Excellent.
It's good. So what do you guys think? Fawaz and panelists?
Perfect.
Although we didn't say anything yet, but the audience couldn't hold themselves for clapping greatly with the great results. So all people happy here that it's we're expecting something challenging, and you make it very easy for us. The valve deployed.
So one last.
Hamid,
Thank
we
you,
don't
Fawaz.
want
One
to
last
butter you
note
up,
to the-
but I think the panel and the whole think it's a perfect
So
result.
you
Couldn't be done
keep,
better, brother.
You're happy with the 15 of mean?
It's good.
No,
It's
the answer is no. Sorry, because
So what would you suggest?
Because, Hamid, this is important because you don't want structural valve degeneration in this particular case because she's still 73. There is no diabetes, so she's expected to outlive her valve. So you have to perfect the valve. Sorry to say that, but you know that probably to minimize her having a second valve and valve, you have to perfect this valve. So Anything 10 and more, I don't think it's acceptable in this case. So, sorry to push you, but the second point is that you see the calcium in the left cusp is just below the origin of the left main, just supporting the left main. So you have to,
It's probably, Muhammad, more than just this. It's actually probably half.
So sorry, what's the gradient you're getting?
Well, almost no gradient.
Okay,
So we'll take a question from Dr. Ahmed Al-Shatti.
For the gradient, I think just the pigtail is way too deep in a lady. So if you can pull the pigtail a bit in the LV, just in the LVOT, just to check the gradients.
Excellent. Hamid, we have 5 minutes. So do you have any final words before we go to panelists and audience?
So what we'll do, we'll just wait because, these expanded platform will continue to expand. We'll just check it. If it's not coming down, we'll discuss it with the team. I think overall, looking at the, complexity in this case, honestly, I don't want to push my luck. Okay, I don't have significant paravalvular leak. It's suboptimal mean, but I think it's in the gradual scheme of things. I think it's acceptable.
Hamid, I would really be skeptical about going in with a post-dilatation at this stage because it would be pushing your luck.
Yeah, I agree.
And the chances
Absolutely.
of, ideally, yes, you want to perfect it, but you do run the risk of coronary obstruction at this stage.
I'm not quite sure. It's already mentioned by Dr. Shatti. That's your big tail too. You need to have a better tracing, and I'm sure the gradient will be okay.
I think I agree with the low left main, but the message should be this valve, if there was no left main, should be better optimized because there's a paravalvular leak and a gradient. But in this case, I agree with the panelists. You do want to push your luck with the post-dilatation.
Again, with that LVOT classification, ending up with a bit of paravalvular leak is not entirely surprising, I have to admit. But I think what you're saying is...
one more thing, Fawaz. I think post-dilatation might actually increase the risk of requirement for pacing. So, I would be happy without that risk. What is it? Now the mean gradient is down to 12. I think we're happy. So, guys, thank you so much for the activities. Thank you for your feedback. And hopefully we'll see you soon. Thank you so much.
Thank you very much, Hamid.
Thank you. Thank you so much. Well, guys, thank you so
We have
much.
extra 3 minutes. Hamid and Dr. Hussein, I think you did a great job. A very complex case, a lot of challenges from the access, coronary calcification, and the risk of a stroke. And I think you made it easy for us. The result is great, and I think you did the maximum that you can do. A great final result. And just one word from each panelist, and just take home message that what we'd like to deliver to our audience, what we learn from this specific case. Dr.
One question I would like to ask myself, which valve I have to choose from the very beginning. I agree with Dr. Ahmed that the Edward valve for this patient particularly, it might increase the risk of coronary occlusion. But is it better to use an intraannular valve rather than supraannular for this patient? Probably if I use a Saud valve, I will give a better chance for the left main accessibility for this patient if we have a risk that we are going to deal with this patient coronaries later on, because acutely we don't have any compromise to the leaflet, but the long term of this mechanical is a different disease. We don't know what is the behavior of this leaflet with the long term. So if we have the option that if we have that these valves are similar, for this particular patient, I use an intraannular platform. In spite, it would have a bit higher gradient, but it will give us a better accessibility to the coronary.
Great. Dr. Faisal?
I think, which I saw in the CT scan, there was extension of calcium in the LVOT. That make the maybe relatively contraindication to put Edward, because the possibility of perforation is high, especially as female in her 70s. So I think what she chooses is right, and I like what they did.
And VOT self-expandable also is better.
No, I think it was an excellent case, and an excellent pre-procedural planning made this difficult case go very smoothly.
Excellent.
Yeah, I think wonderful case. The key issue was the proper planning, analysis of the anatomy, and not to challenge your luck more than this. That's the key.
I think that's great. If you know exactly what you are doing, what is the next level, and I think it's the almost safer. Dr. Ahmed?
No, I love what they did. Perhaps I would have spent some more time with the balloon interrogation, probably a bit higher, slightly larger balloon. There were a couple of very useful comments on how to do the proper injection, where to put your pigtail. I would usually start injecting just before the balloon reaches its maximal expansion, just to make sure I get some flow into the sinuses before the balloon occludes the flow. But on the whole, this was very carefully planned and done in a very smooth and efficient way.
Great.
Congrats.
Dr. Khalid, just 10 seconds.
No, just a great job. I think this patient has benefited now from the TAVI with a faster recovery, and it will last. She's 73. It will last her for a long time, compared of the increased surgical risk if we would have done surgery.
Dr. Mohammed.
This is a beautiful case, beautiful demonstration. If I have other options, I will use intraannular self-expanding.
I'm still
This is
thinking
the
with the
best.
LVOT that we have to take it in consideration. I will allow Dr. Shadda to say something
I
because
think by pulling the pigtail, already the mid-cavitary gradient is gone. They are measuring it again right away now, and it's gone. The gradient is gone. That was a mid-cavitary gradient, not a real gradient.
great. Dr. Hamid, Dr. Hussein, dear panelists and audience, I think it was a great case. We saw a lot of challenges and treated appropriately and nicely. A great result. Thank you very much, and we'll open a second session.
Okay, guys.